First, we're going to start off about some grandfathering provisions. This did not get a lot of press. And frankly, after the reconciliation bill, you can kind of see why, because first it was giveth, then it was kind of taketh away. But as a starting point, are there any of today's employer plans that are affected by reform? And the answer to that is yes. If you have an employer plan that is affected by these pieces of legislation, group health plans in effect on the date of enactment, that was the 23rd and the 30th, are exempt from, I say, many of the health care reforms, but they're probably have to comply with what I'll call the major ones. The grandfather rule not only includes individuals that are covered under today's plans, but it's going to take into consideration new employees and their families that are covered under a grandfather plan as they come on between now and the effective date of the plan, and any family members or current members who are covered by the grandfathered plans. The grandfathered plans are permanently, I'm not sure if you can agree with anything that's permanent in this, but permanently exempt from certain of the following reforms. And I've listed those, and they're on your sheets, but some of those: preventative services, limits on cost sharing. Brian will get into some of the non-discrimination rules imposed. Briefly, that's just self-funded plans used to have, or do have, discrimination standards, but fully insured plans may now. Certain reporting requirements, some of the appeals process. All of the things listed on this slide we will cover in more depth as the presentation goes on, but these are permanent exemptions for grandfathered plans. There are certain plans that are subject to the following requirements. In other words, they weren't exempt from these particular ones. Changes in the tax rules relating to health plans. Brett will touch on that. Dan will get in depth on that. The uniform coverage rule, that will apply to all plans regardless of the grandfather rule. Cost reporting and rebates. Automatic enrollment. Notification of availability of the exchanges. I'll spend time talking about the exchanges. Notices regarding exchange and requirements to provide employees with certain vouchers. All those, even grandfathered plans, are subject to those. Along came the reconciliation bill a week later, and the reconciliation bill subjects otherwise grandfathered plans to even more requirements. And these are the kind of the ones that you're going to feel the most and you're going to feel the quickest. Limitation on lifetime and annual limits. That FPY means fiscal plan year, 6 months after enactment. And we'll talk about that in a moment, just what that means for calendar year plans, etc. The limitation on pre-X conditions. They're subject to that. Prohibition on rescissions. That's an insurance carrier actually pulling the coverage away. And I'll talk about that a little bit. Limitation on waiting periods. They're subject to that. And finally, the coverage of adult children. So really the items that got the most press, frankly, grandfathered plans are covered by them. There's some little minutia things that they're not, but by and large, if you've got a plan now, the plan is in for some big changes in the not too distant future. I'm going to move to what I'll call immediate health reform. And by immediate health reform, what I mean are changes that will affect plan years beginning 6 months after the date of enrollment. So if you fast forward, that's basically October 1 plan years. Most of you, although we have a lot of fiscal plan years, that if you have a calendar year plans, you're looking for the immediate health care reform changes to take effect January 1, 2011. That's a really important date. If you happen to be either a fully insured plan or a self-funded plan that has an October 1 or a November 1 or a December 1 plan year, you will be subject to these rules later in 2010. So that's really important to remember when you're going to be subject to these. If you're fully insured, trust me, you'll be reminded because your insurance carrier is going to be responsible for most of the design changes. Talk a little bit about the things that I just mentioned sort of parenthetically. Annual and lifetime limits. Plans may not impose lifetime limits, and only restricted annual limits as determined by the Health and Human Services, that's what that acronym HHS stands for, on the value of essential benefits. And we'll talk about what essential benefits are just a little bit later. Most of you, probably all of you, are familiar with things like perhaps a $2 million lifetime max on your plan. That's very common. Some are $5 million. So if you're a calendar year plan, that'll go away starting January 1st of 2011. Some of you may have annual limits on certain items. Now, some recent legislation targeted what a lot of plans use for annual limits, and that's mental health and substance use. And you're just getting subject to those rules now, but there may have been an annual limit on certain mental health issues. That's gone away because of another law, but any other annual limits on lifetime maximums will go away permanently as well, and that'll happen depending on what it is, anywhere from January 1st of 2011 to January 1st of 2014. There are certain parts of the new law, as there is with any law, that in my opinion, and I think in some ways you sort of want our opinion, we've all been doing this a long time, there might be a broad brush, a broad stroke, or maybe just a little exercise of too much government. This might be one of those areas. There's a prohibition on rescission saying plans just can't dump you. I've been doing this a long, long time, and I would have to say that I could count on one hand and have a lot of fingers left where plans just said, you know, no thanks, we don't want you anymore. And particularly in Nebraska, where we have small group health reform since 1994, if you're 50 lives or under, really they have to take you anyway. When they're bidding you, they can give you a manual rate and bid it up 67%, but you can get coverage. And once you have coverage, they can bind it at 15% above what really amounts to a community rating. So in Nebraska, anyway, you don't see a lot of companies getting dumped. And if it's a larger group, frankly, and I know we have some representatives of insurance carriers here today, it's bad publicity for an insurance carrier to go to a 200-life group and say, we don't want you anymore. Typically what they'll do is they'll just raise the rates and force you to bid, and if you can find somewhere else, you move on. But there is a prohibition on rescission, so you need to know that. So plans may not rescind coverage except in case of fraud or intentional misrepresentation. I have seen that once or twice in all these years where somebody sort of forgot to tell the truth about medical underwriting and they've pulled the coverage, but that's very rare. So we have a part of the plan that restricts this, but I don't see that as probably the biggest issue we've had in healthcare in this country. Coverage for preventative care. Plans must provide first dollar coverage. That means no cost sharing for certain evidence-based preventative care, including well child care and certain immunizations. This is a good thing. Certainly hard to argue about that. I would note that many plans already provide this. In the state of Nebraska, in the mid-90s, we had provisions that mandated this for fully insured contracts, that you had to cover immunizations for children up to 6 on a first dollar basis. So this might impact some self-funded plans, but by and large, a lot of fully insured plans already cover the bulk of this. And this, once again, is something that's going to be subject, all of these are January 1 for your calendar year plan of 2011. Coverage for adult children. It just so happens that, and I have never thought that Nebraska was on the bleeding edge of healthcare. I think we're up to date. I think we're kind of in swing. We let other states take the lead and see if it works. I think we've kind of generally approached it pretty well. But for those of you who have plans or work with plans, this might be a little bit repetitive because last year we had LB 551 in the state of Nebraska. And what that said, and it's different from this, but let me draw the comparisons. LB 551 said that you could continue to cover an adult child up to age 30. And they should have called this the Sorrentino rule because I don't think any of my children are ever going to get jobs. They're all going to be on my plan till they're 30. But what it really said was they could continue coverage, but really as a single individual. So if I have, it seems like 12 children, but I only have 4. So if I have 7 covered right now, and 2 of them are 28-year-old grad students, they can continue to be covered in the state of Nebraska, but it's at a single rate, and it's at a single COBRA rate. So at SilverStone's case, that could be a $400 premium. What healthcare reform is doing is they can basically stay on my plan as if it was a 12-year-old child. So it does expand what Nebraska offered, but on the other hand, it's not age 30, it's age 26. There's already 37 states who have enacted legislation similar to this. A lot of them have chosen age 26, some are 28, some are 30. But plans that cover dependent children must provide for coverage of unmarried children. You'll notice in the second bullet point, there is no requirement to cover children of covered dependent children. And that's come up for a lot of years. I mean, if you have a child under your plan that has a child, does that child have coverage? So we've addressed this before, mostly in COBRA regulations, but the reconciliation bill does extend the requirement, this was a week later, to married children and extends tax exclusions for employee-provided coverage to adult children under age 26. I always thought that if my kids got married, that'd be the one way to get rid of them, but apparently that's not the case. Transparency requirements. Transparency gets a lot of press these days. And that's because during the politics of all this, there was a claim that insurance carriers they're dealing from underneath the table. They're not transparent. They don't show their minimum loss ratios. Brett will talk about that later. And there was suspect, and they were making lots of money. And in California, I think WellPoint had to go before Congress and substantiate 29% increases when the company had made a lot of money. Well, so transparency is kind of the new buzzword for 2010. Group health plans, both self-funded and insurers, will be subject to the same transparency requirements applicable to plans offered in the state exchanges. Well, that doesn't tell us a lot yet because the state exchanges aren't going to come into play until 2014. But what we do know is that the state exchanges, which will not be public option plans or privately offered plans, will have a ton of reporting requirements that we'll get into later, so that transparency is kind of the buzzword. Specifically, they have to provide to the Health and Human Services claims payment policies and data, financial disclosures, enrollment and disenrollment data. I'm not sure what they're going to do with disenrollment data, and information on cost sharing. But what I would caution you here, and I was going to save it for another slide, but it seems more appropriate now, anytime you see the word report or comply or obtain or remit or submit, a little cash register needs to go off in your brain. Because if somebody has to do that, that's a verb. And when you see a verb, that means a responsibility. And responsibility means that's either going to go to an insurance carrier who will have to price it in to the cost of the administration. And I don't blame them, I would too. Or to a self-funded plan, that means more man hours or woman hours to administer a plan. So we're going to see that one of those kind of interchangeable verbs a lot. And that means money. Non-discrimination rules for insured plans. I'm just going to touch on this because I think Brian will go into it a little bit later. It'll apply to fully insured plans as well. I won't go into the details. There's just a cadre of tests that you have to do. The one thing I would say, most of you, and I'm real familiar with most of your plan designs, they're not designed in such a way that you're probably discriminatory anyway. You look at your contributions. Do you pay the same towards highly compensated versus non-highly compensated? You look at the benefits. Are they the same? If you can roughly pass those two facts and circumstances, you're probably going to be okay. The one thing I would say is if you sponsor some sort of an executive reimbursement plan, sometimes known as ExecuCare, those are discriminatory by nature. That's the intent of those. Those will come under new scrutiny, and we'll have to take a harder look at those. Pre-existing conditions have also gotten a lot of press. Checking my time here. With respect to children under 19, not others. That comes in later. That's Brett's thunder for 2014. But with respect to kids under 19, plans may not impose a pre-ex exclusion or limitation. By and large, first of all, that's fine. You don't see a lot of pre-existing conditions for kids under 19 because we all know until we're 25 we're bulletproof and we don't even need insurance. So that's not as big a deal as it might sound. Claims procedures. Claims have got a lot of attention since 2002 when we had just a boatload of laws that made us go into our SPDs and our plan docs and change that. Most of you know from that amendment process that it's long and drawn out, and there's pre and post and all kinds of other tests and amendment procedures, 60 days and 75 days in appeals. This establishes two types of claims appeals process. There's an internal, which I address on this slide, and an external. Largely an internal is how an employee communicates with the administrator of their plan, if it's self-funded or the insurance carrier. Specifically, and this is kind of a common thread throughout the Act, it has to provide notice in culturally and linguistically appropriate manner. That's hard to say when you get to linguistics, of the review process and the availability of applicable health insurance ombudsman created by the state. So never let it be said that this law is a jobs killer. It's going to create a lot of jobs. It just happens to be in the insurance industry. It's going to allow claimants to review the entire claim file and present evidence. The attorney in me sees problems with that. You're handing over claims files. I know it's my own PHI. It's my own protected health information. I can see that being passed around at lunch table. I'm volunteering my PHI. I can see lawsuits. This looks like a problem to me down the road, but that's what the law says. It allows claimants to continue receiving coverage during the appeals process. I find that particular thing interesting because I'm not aware of anybody who's been cut off during the appeals process, but it specifically makes a point that it must be continued. There's an external claims process. They must comply with applicable state law. In a lot of cases, I think that state law still has to be promulgated. So in Nebraska, we'll look to the unicameral sometime for that. Probably in the next session. This is an immediate health care reform issue. I believe that the legislature closes here in about the next week, not to reconvene until January of next year, so we could have a special session on that, or we might rely on something in the second bullet point, any external review model act. It's the NAIC, and we have a very active NAIC model act in Nebraska, so I think that'll be taken care of in that fashion. Patient protections. Plan enrollees are allowed to select their primary care provider. In most cases, they are already, or pediatrician in the case of a child. And in most plans, the panel is enrolled in such a way that pediatricians are considered primary care physicians. The two key words in this bullet point are from any available participating primary care providers. Available means the providers can say they're full. And if they say they're full, they're still within the spirit of compliance with the law. Participating, that means that the plans don't have to expand the network. If you've got 87% of the care providers, that's enough. You don't have to expand that. Now, there's something buried in the law that I didn't put on the slide that I don't particularly care for, but the federal government does reserve the right that if, in their opinion, panels are not wide enough and there's a shortage of primary care physicians, which if you listen to the AMA circles there is going to be, that they can force plans in the exchange and then later out of the exchange to expand their panels. So that's kind of in there. That could be a fallback. I'm not sure where they're going to go with that. This law does preclude the need for prior authorization or increased cost sharing for emergency service, whether they're provided in or out of network. I'm not so sure I think this is a quality provision. We've taken great pains in most of our plan designs to try to get people to go to the doctor during the day, try to see a primary care physician, use the gatekeeper approach where it's available, and not use emergency rooms. So in its strictest constriction, what this might say is penalties for using emergency services may be out the door. I want to wait for some enabling regulations before I would make a judgment on that. It does preclude plans from requiring authorization or referral by the plan for obstetrical or gynecological care. Most plans are there anyway, so I don't know that that's that big of a deal. High-risk pools. Until the high-risk pool established under PAPICA for individuals with pre-X is terminated in 2014, which is when the exchanges come into play, a group health plan must reimburse the high-risk pool for medical expenses incurred by the pool for individuals. That's just to take care of the catastrophic losses. There's going to be a pool out there. It needs to be reimbursed. When the exchanges come in, this provision will go away. There's already sanctions, if you'll notice in the bottom of that bullet point, incurred by the pool for individuals found to have been offered financial incentives to disenroll for health plans. This is where I think the law got a little broad as well. There's already, when you see this most of the time, it's an older employee. Everybody knows that it's against the law to incent an older employee who's eligible for Medicare or Medicaid, doesn't have to be older, could be because of sickness, to leave the group health plan, give them a financial incentive, say, look, I'll give you $400 a month just to get off the plan and get off my experience. You can't do that. And you haven't been able to do that for 25 years. So I'm not sure where this point of the law is going, if they think there's an abuse of that and it's not being caught. But we've broached that with employers a number of times, and they've come to us saying, is there anything I can say or do? Outside of explaining to a plan participant that they're eligible for Medicare and Medicaid, you can never incent them to do that. So I'm not sure, this might be another case where a little bit of a broad reach on the statutes. We'll have to wait for the regulations. Electronic transaction standards, we've been high-teched and HIPAA'd to death. This is kind of a repetition of that. The plans must implement certain electronic transaction standards. If you are fully insured, this is going to be taken care of by the carrier. If you're self-insured, it's going to be taken care of either by your ASO provider or your TPA, so I won't spend a lot of time on that because I'm way over my head when it gets to electronic standard codes. PAPICA provides funds to states to establish a health insurance exchange. This is going to be for individuals who have to purchase health insurance under the individual requirements starting in 2014. Although everybody thinks that exchange is for individuals, it's also for groups. States can decide on they call it a shop exchange, what groups can buy it based on their size. If you go to the next slide, I go into a little bit more detail there. Employers are impacted by the exchange because beginning in 2017, states may allow all employers, regardless of their size, to offer coverage to the exchange. They don't have to, but they can. That's going to go state by state. For 2016, only employers with less than 100 employees may participate, and for years before 2016, a state can allow small employers. This exchange will be an invitation to insurance carriers to participate. As I mentioned in the early House version, it was a public plan option. The public plan would compete with the private options. That went away under the Senate version that was adopted on the 23rd, and it was not changed under the Reconciliation Act. Those exchanges, while they've got a lot of buzz, they're 3.5 years away. So we've got a little bit of while to deal with that. It'll be interesting from my standpoint just what carriers will jump in our state. Will they all jump in, or will they evaluate it and say, gee, this is a pool that I don't want to be in? We'll see. Employers who offer coverage through the exchange may permit employees to offer such coverage with pre-tax dollars through a cafeteria plan. I'm not going to go there because that's Brian's area. But if the exchange-related coverage is not offered to the employer, you cannot use the cafeteria plan. I mentioned earlier essential benefits and what they are. I'll try to give you a very quick overview of what they are. The bill requires the Secretary of the Department of Health and Human Services to establish these essential benefits, and they're going to be used to determine the 4 types of coverage that are under that exchange. And they very cleverly called them bronze, silver, gold, and platinum. There's actuarial values that I'll touch on the next slide, but all individual, and in some cases small group insurers, would have to offer at a minimum plans in the silver and gold. If you want to try to relate what that means, if you remember when Congress decided that we could have Medicare supplement plans, they offered them in letters A through I, and carriers kind of decided which plans they would participate in. Most carriers picked A, which was the low level, and maybe something or towards H or I and something in the middle. I doubt all carriers will offer all 4 options, but they do have to at least offer the silver and the gold value. All right? Remember, it's 2014. Continuing on, the essential benefits. This slide is a little wordy, but it kind of tells you what needs to be in there. I'm going to pick on just a few things. Right in the middle of that slide, it talks about mental health and substance use disorder services, including behavioral health treatment. That's interesting. I mentioned earlier the Mental Health Parity Act, and then it was subsequently, most recently, amended to talk about mental health and substance use. What that act said is you couldn't have any annual or lifetime limits on those kind of benefits, no daytime. You got to treat it same as any other sickness. But what that law said is if you don't want to cover it at all, you don't have to. So if you don't have it under your plan now, you don't have to worry about removing the limits. What this says in 2014, an essential benefits plan will include it. So your window, if you will, to say, I choose not to do that, is basically about 3 years and 9 months. And any essential benefits plan after that will have to have that. I'll pick on wellness services. Wellness services generally aren't, they are to some degree. Self-funded plans, we see it a lot more. But in fully insured plans, there's not a lot of wellness benefits. You might have first dollar coverage for immunizations, that sort of thing, pap smears, mammograms. But I think this is going to go a little further as we get regulations. I think you're going to see an expansion of wellness services to be considered an essential benefits plan. And then finally, the very last item, oral and vision care. Most plans don't cover that. And that will be part of the essential benefit plans, both the exchanges and in certain private plans. On the next slide, each level of coverage must meet its own actuarial value of the mandatory covered services. And it goes through the 90, 60, 70, 80, 90. The only reason I bring this up is when Brett talks about Cadillac tax, and he'll tell you that, gee, if a plan has a certain value, you might have to pay a tax. When you look at actuarial values, that's based on what's covered under a plan. I just showed you a slide where essential benefits have been expanded. So that means the actuarial value of that plan will be higher. We might, by 2018, be bumping up against some of those values that could trigger the Cadillac tax. It'll depend what insurance carriers deem to be appropriate to add to the coverages between now and then. There's a separate catastrophic only policy would be available for those 30 and younger. Frankly, that's a really good idea. When you're 30 and bulletproof, you don't need first dollar coverage. Plans can offer child-only coverage through the exchanges to meet the child-specific benefit provisions. Not sure how that's going to work, frankly. That takes you to the things that you need to know in the next 90 days. It touches on some things as an intro to Brett. I've been at 50,000 feet, like I like to say. Brett's going to take you in from here, and I'll turn it over to Brett.